Hello, I'm Norman Swan. Welcome to the new Bush Telegraph, Telehealth for Rural and Remote Practice, coming to you on the Rural Health Channel. On behalf of everyone, I'd like to acknowledge that this program is being broadcast from the land of the Wango people of the Darug tribe, traditional custodians of the land and part of the Eora Nation. And we acknowledge their elders, past and present. Telehealth is nothing new. We've been using the telephone for as long as it's existed for health information, including sending data long before there were computers. What's new are telecommunications networks that allow video conferencing and the transmission, of detailed images. And of course, now the availability of Medicare rebates. Over the last year or so, over 20,000 patients and 6,500 clinicians have taken part in telehealth consultations, which have saved time, money and smoothed care in many instances. But that's a tiny proportion of the total business in healthcare, so the potential is still enormous, and that's what this programme is about. What's stopping some practices from putting telehealth in place and how to overcome those barriers? We'll hear from our panellists of their experiences using telehealth and how their patients are reacting to seeing their doctor on screen rather than in person, and what telehealth has meant to them and their healthcare teams. We'll also help clinicians watching who don't know where to start, and I assume that's a few of you. This is a professionally accredited programme from the Rural Health Education Foundation, broadcast on the Rural Health Channel. It's also been broadcast simultaneously via a live online webcast and on NITV. As with all our live programmes, we want to hear your questions to the panel or comments, and you can get in touch by phone, text, email, fax or by computer. And the details are on your screen now. The emails can go to questions@rhef.com.au. You can text us on 0408 408 932, or you can phone us on 1800 817 268 and we'll put you on air. And, you know, if you've got something, does anybody use fax anymore? But if you do, you can fax us on 1800 633 410. And if you're watching via the webcast on your computer, you can type your questions or comments into the live talk box and click submit. So we're taking questions and comments live throughout the panel discussions, so send them in as they arise from now on. Now, for those of you on computer, it would be interesting to know who's interested in telehealth, so let us know what group you're in. Are you a consumer, a general practitioner, a nurse, an Aboriginal and Torres Strait Islander health worker, a specialist, or a manager? So click the answer on your computer and we'll get the results shortly. Let's meet our panel. Ewan McPhee is a rural procedural general practitioner practicing in Emerald in Queensland. He wears many hats, including being a VMO in obstetrics at the local hospital, deputy chair of the Central Queensland Medicare Local, immediate past president of Rural Doctors Association of Queensland, and a member of the statewide Rural Clinical Network for Queensland Health, the latest clinical network in Queensland.
Yes, it's a lot of good work to be done in rural and regional Australia.
So welcome to the programme, Ewan.
Thank you.
Ewan's also been working as part of ACRIM's Telehealth Advisory Committee. When do you have time for your day job?
Well, it's got to be, well, you give a job to a busy person, I suppose,
right.
And get things done.
Isabel Ellis, Professor Isabel Ellis, is a nurse and a midwife who has worked for many years in rural and remote Australia as a clinician, educator, health service manager and researcher. Isabel was the inaugural telehealth coordinator for the Kimberley region of Western Australia and is currently working for the Tasmanian Department of Health and Human Services to establish telehealth services in the northwest of the state. Isabel is chair of the University of Tasmania's eHealth Research Centre. Welcome, Isabel.
Thank you, Norman.
You've moved from one remote area to a slightly less remote area?
It doesn't feel less remote at times.
Don't I hear people in Burnie saying that?
True, but Tasmania has a lot of very, very beautiful remote areas, and so it's a very special place to be.
Plenty potential for telehealth.
Absolutely.
Carol Bennett is the Chief Executive Officer of Consumers Health Forum of Australia, the peak national organisation for health consumers in Australia, leading its work to ensure a strong consumer voice and consumer participation in health reform. Welcome, Carol.
Thank you, Norman.
CHF works to achieve safe, good quality and timely healthcare for all Australians, and therefore sees telehealth as an important mechanism to achieve this, especially for those living in rural and remote areas. I need to make a declaration here that my wife is chair of the board, so Carol needs to behave. Associate Professor Sabi Sabison is the Director of Medical Oncology and Senior Staff Specialist in Townsville Hospital in Queensland and Clinical Dean of the Clinical School at Townsville Clinical School at James Cook University. Welcome, Sabi.
Thank you.
Sabi's been involved in telehealth for the last 6 years and is a passionate advocate for its wider use. You must have seen some changes, Sabi.
Many changes through gentle persuasion of the colleagues, mainly.
You're fed up telling people about the benefits. You just want to tell them how to do it now.
Yeah, exactly. I mean, we've been doing it for 6 years, and now I could see so many other potentials. So I want people to take up and come up with new models of care to help the rural Australians.
And we'll talk about those later. Di Thornton has been nursing for a long time in both rural and metropolitan areas, despite how young she looks. But in fact, she prefers to live and work in the rural setting. Welcome, Di.
Thank you, Norman.
And for the past years, Di has been the Executive Officer and Director of Nursing at Pinaroo Soldiers Memorial Hospital in rural South Australia, and in her spare time is a farmer's wife. You're another one who's got no time for the day job. Di is a passionate advocate for the use of anything technological that will improve access and reduce travelling for rural people. And proving that this technology works, we also have joining us via video conference from Western Australia, Associate Professor Angus Turner. Angus is an ophthalmologist based in Western Australia, is actively involved in delivering specialist eye services to remote and Indigenous communities with a particular focus on the Kimberley and Pilbara regions. Welcome, Angus.
Thank you very much.
Angus is also involved in research and working on a number of research projects at the Lions Eye Institute in WA, focusing on service delivery to remote and Indigenous peoples. Welcome to you all.
Thank you.
So let's get the results of poll question 1. So consumers are 4%, 7.5% for GPs, 35% nurses, and we have no Aboriginal Torres Strait Islander health workers. This is on computer, not watching line. 20% specialists and 32% managers. So that's who's watching, at least by computers. Let's go to our next poll question. For those clinicians watching or health professionals watching, are you already using telehealth? Yes, at least weekly. Yes, less frequently. No. What are your answers to those questions? Ewan, how long have you been using telehealth?
Well, I've been using it for about 12 months quite regularly now.
What does regularly for you mean?
Well, at the moment we probably do between 5 to 10 to 15 consultations via telehealth every week now.
And are you in a single-handed practice or?
No, I'm the principal of a small group practice, predominantly a teaching practice with a number of GP registrars.
So you're all using it?
Yes. Yeah.
Everybody's converted?
Well, everybody's converted, but being the boss, you know, you have to
lead from the front?
Lead from the front, but also a bit of prodding, I guess. Too.
So let's just go through the technical stuff, because the rules have changed a bit and what's available. So who's eligible? I mean, well, first of all, how do they define telehealth? It's only video conferencing, isn't it?
Basically, at the moment, it's a simulated face-to-face consultation, and the MBS item numbers really are specific for non-admitted and not for ED patients either. And the patient has to be located outside of RA1. The patient and the physician have to be at least 15 kilometres apart, and but also does include residential aged care facilities and eligible Aboriginal medical services as well. So, the people that can do this are specialists, consultant physicians, psychiatrists, but also medical practitioners, midwives, nurse practitioners, practice nurses, Aboriginal and Torres Strait Islander health workers.
And the Medicare, there's quite a lot of items, aren't there?
There are, but I mean, in my situation, I've got a practice manager, my lovely wife, who knows the item numbers very well. But I mean, it's very practical in as much as you can look at the MBS online, look at the item numbers that are specific to your own circumstances. There is 17 for specialist services, including some new items, and 23 for patient end services, whether they occurring in the consulting room, the patient's home, or in an AMS or an aged care facility. And
how long did it take you to get up and going?
Look, we didn't take long at all. the technology is freely and easily available. We needed a good internet connection and a reasonable camera. What really helped us was having specialists on board who were keen to get up and get running.
So you had somebody to talk to.
That's right.
Angus, how are you using it?
Well, I've been using it based in Perth as an adjunct to the outreach ophthalmology services that we have throughout the Kimberley and Pilbara. And most places we only attend as an ophthalmology team about 2 to 4 times per year. So we've been using it in between times for follow-up and also sometimes preceding a trip to start some management. And that means when we see the person in life, real life, we actually have already started something and can see how it's going. But it's also being used with quite a few emergency calls that come in relating to a red sore eye or some problem from a GP up in the north. Interestingly, for our purposes with the eye, optometrists have actually been very keen on the technology and have used the service more than anyone else. However, they're not actually part of the Medicare rebates or any of the telehealth changes. So it'll be interesting to see how this area changes in future.
So they're doing it for love?
They are doing it for love, and hopefully that shows that it's actually quite helpful for them because there are regionally based optometrists. For example, a town like Karratha only has one optometrist full-time, so that person sees a lot of medical problems different to perhaps an optometrist in an urban area, and the support offered through telehealth is really beneficial.
I mean, it takes quite a bit of trust. I mean, if you've got somebody, say, with maybe a query detachment, you've got to be sure that the optometrist is looking properly.
Well, it's true to a degree that the important thing for eyes is having a good picture. So we need a picture of the front of the eye, but also the back. And the technology for taking photographs of the back of the eye is truly extraordinary. It changes every 6 months. I can't keep up with the new cameras. And many of them are getting cheaper, more accessible. And we're discovering that the smartphones, the computers in our pockets, are actually taking superb images of the eye. So it's a pretty exciting area for ophthalmology.
We'll come back to some of the issues in a moment. Let's get the answers to poll question 2 about whether you're already using telehealth. 13% of you say yes, 17% less frequently, and 70% no. Well, stay watching. We'll see if we convinced you at the end of the program. We'll try and find out why. And before we go on, let's go to another poll question for those watching on your computer. What are the views of your patients on about telehealth? They like it? They think it's too impersonal? They can't understand the person at the other end? Technical problems get in the way. Obviously, these are questions for clinicians whose patients are actually using using video conferencing and telehealth, and we'll come to those answers in a moment. But Carol, you've actually surveyed consumers about this.
We have. We've talked to consumers all around the country about telehealth and about the benefits that they see resulting from using that service. And a recent poll that we did indicated that 90% of the people that responded to the survey said that they were aware of telehealth and its benefits, and 50% of those had either used telehealth and found it beneficial or would use telehealth if they were offered the service. So there's a lot of scope, I think, for consumers to be made aware of the benefits, but certainly there's a lot of interest by many people out there to use these services. And the stories that we hear from rural areas in particular, rural and remote areas where people have, say, diabetes that can be managed really well through telehealth, in rural Western Australia, to the woman in Queensland in a rural area who has breast cancer, who needs ongoing management and follow-up, through to the young toddler in rural New South Wales who might have eczema that requires quarterly visits to a specialist, but can actually be managed quite well through telehealth.
What do you think the role of the consumer is in actually getting more clinicians to take it up?
Well, I think consumers can drive demand, and if they can see the benefits and how that can help them, and if they know people that are using these services and getting the benefits of those, and they understand what that is, then I think they can drive demand. And certainly the benefits really come in terms of the cost savings to consumers, the time saving, and the convenience. When people don't have to go to the city, the costs involved in the travel, the accommodation, but also costs in terms of work time lost, having to take other siblings out of school to get them to these appointments, and all of the inconvenience that goes with having to get to the city for appointments when it can be managed really well through these services.
You're using telehealth, Di, in the most acute situation imaginable.
We don't have resident GPs in Pinaroo, and if we have emergencies like an MVA, which is what we had last week, motor vehicle accident, we had a fellow that we managed via the video conference while MedStar, our retrieval team, were in flight on the way to us, and we had the intensive care specialist on the other end of the line, and it's like he's in the room with you, and it's such a good support, and he can manipulate the camera. He can see, he can zoom into the monitor, he can do whatever he needs to do and leave us to do the physical stuff and, you know, say to us, how about you go and do that, let's look at that next, and it's great. It just works like he's there in the room with you.
And so this saves lives?
It does save lives.
So it's the difference between something and nothing, but something's pretty good quality.
Yeah.
It's just that you don't have somebody to put in the difficult drip for you, you've got to do that yourself, that's the scary bit.
We've got pretty good at that, actually.
And who funds that?
The Telehealth unit has been funded by the state through Country Health SA.
Right. And what else are you using it for?
A myriad of things. Patient-wise, we've used it for consultations with oncologists. When we've had people at home in the community who are too sick to travel to see their oncologist. We use it for meetings, we've used it for training. We've used it mental health for some of our consumers having cognitive behavioural therapy, linking up with one of the psychiatrists down at Rural and Remote. Really, the options are endless. And
no problem finding a specialist at the other end?
No.
Let's go to your answers to poll question 3, which are what are the views of your patients? 64% of you say they like it. Nobody thinks it's too impersonal. About 1 in 5 think that they can't understand the person at the other end, and 1 in 5 technical problems get in the way. Sabi, has that been your experience?
My experience has been mixed, but in terms of patients, I agree with the poll. Majority of them actually like it because of the benefits Carol was talking about. But in terms of the...
But it's not perfect.
It's not perfect because it's same as the face-to-face. You know, if you interview 100 patients who've been to a face-to-face clinic, and you're not going to get a perfect satisfaction rate in those.
Carol would say, if only you would interview 100 patients who've been to your clinic to get a view.
Yeah, so certainly the patient perspectives are the same as the polls. The technological aspects, it happened maybe early in the piece 5 years ago, but now everyone is familiar with the technology and how to operate, so that's not an issue anymore.
So just describe your model of care, what happens, because it's extraordinary. I mean, there's been a transformation.
But for us, the model evolved over time, over the last 5 years. That really reflects the fact that once you start simple and then you build on your experience and make it complex. So when we first started 5 years ago, every new patient had to come and see us face-to-face in Townsville. And then for follow-up, we could use the video link. And for the first chemotherapy, they had to have it in Townsville. And the simple ones could be done in Mount Isa. And the complex one had to be done in Townsville. And then after a couple of years, we had done some patient satisfaction surveys. And they liked it, and they trust the system. And then we said, OK, they have to still come and see us, but they don't have to have the treatment in Townsville. And then a couple of years later, we realized we actually don't even need to see the patients if the patients don't want to see us. So we offer that.
Sabi, I'm sure that's, you know, it's really about trusting the people on the ground in, you know, the service providers, the general practitioners, the nurses who are there to provide that support, that you don't feel that you have to see the patient for every consultation.
So that's actually an interesting point about telehealth. This is exactly what we are trying to achieve, not just seeing patients. And I found in the last 5 years, by shifting specialist services to rural remote communities through telehealth, you are able to expand the scope of practice for the rural practitioners. So that means they are upskilled. They are general nurses, general doctors, general allied health, but they are getting upskilled to the point that the providing end will trust the system. And that will come across when you talk to the patient. And I could now proudly say that whatever service we offer in Townsville or Brisbane is available in Mount Isa. And I tell the patient up front, and I tell them, even if you come to Townsville, same treatment, this is what you will hear. Do you want to come, or are you happy to be there?
And I think it's fantastic that you actually ask consumers what they think of the service, and then you tailor it according to their needs, because that generates confidence amongst the people who are likely to use the service.
I mean, that's what I found with that confidence boosting also. With all the fundings, the government fundings, the tertiary sector tend to absorb it. So the key message here is actually look after the remote side so that that is capable of receiving your specialist services.
So recruitment and retention in Privilege area in other towns might be better because people feel more supported.
Exactly, because...
So tell me about... So you've got a rule now that first consultations are done by telehealth.
That's exactly that. For Mount Isa, it's because we have a full comprehensive service, they are seen anyway, but for the small towns, the 20 other small towns, what we found was a lot of to and fro traveling happens when patients come to Townsville and then realize they needed a scan, they needed a particular blood test. So if you see them first time on telemedicine or telehealth, and if you found that certain things needed to be done, so if they have to come to Townsville, they are all coordinated. So it becomes a little team online. It's a team online.
Who's taking notes at the end of with the patient?
That's again an interesting question, and we expect that the remote end and the providing end takes notes. But my assumption is that whoever provides the service take full responsibility for the care. So I work with that assumption that if there's any other problem with continuity of care, at least the providing end continues with the continuity of care.
So who's the providing end, you or them?
For me, for medical oncology, it's the specialist service we are providing.
You haven't answered my question. Is it a nurse or a doctor at the other end?
That again depends on the complexity of the case and
where you are.
And where you are. If there's no doctor, obviously you can't get a doctor. But in my practice, about 20% of the patients actually don't even... I don't demand a doctor because a lot of the small towns are one doctor, half doctor, fly-in, fly-out doctor towns. I don't want to put extra pressure on them by expecting to be...
And how does it work with Aboriginal communities?
Aboriginal communities, again, we just published Indigenous perspective on telehealth in Australian Journal of Rural Health, I think in October issue. The summary was that the perspective is the same as non-Aboriginal or non-Indigenous population. Same demands, same issues, same travel, same people. So I treat them the same.
So they welcome it as well?
They welcome it.
But there are added benefits as well for Aboriginal communities?
The main thing I really enjoy about telehealth to Aboriginal communities is that when I see one patient, there's at least 8 to 10 family members come with
crowding in.
And there's half of them are young people. And so when I'm talking about...
So the natural support system comes with them, which is impossible when they come to Townsville.
And it's actually, funny thing is, one patient brought their traditional healer with them. So I was able to work with them and give them a comprehensive package. So the other day I was doing a consultation, and that's the good thing about the traditional Tandberg systems. You could actually show the CT scans.
What you're talking about is the proprietary brand of the...
Yeah, so the traditional methods,
system.
You can show the scan. I was showing them where the cancer was, and I could see all the family members were getting interested in the case, and they said, oh, how did that cancer happen? Then I used it as an opportunity to actually talk about the smoking and the impact of smoking on the lung cancer genesis. So I found that the community gets really involved with Indigenous telehealth consultations. But if they had to come to Townsville, one nervous escort will come with that, and the family will miss out the whole thing, and they will get second-hand, third-hand information.
And I would argue that that's a much better service. If you think of what's just been said, what Sav's just been said about the family getting education and also about the practitioners being upskilled, that's got to be better for the communities that are using it.
And giving it to the airlines.
I think that there's an issue though where you've had 5 years to set it up, and a lot of general practitioners are looking at this and thinking, well, how do I initiate it? And of course, with the Queensland Health infrastructure being embedded, quite powerful systems, have you found it more difficult to get GPs online than Queensland Health facilities?
It's actually,
So just to explain here, Queensland works differently, as in all cases from other states, so that there is more emphasis on local hospitals, clinical superintendents who are, or medical superintendents who are both GPs and look after the thing. So a lot of your consults would be to the hospital rather than to GP surgeries.
Yes, certainly that has been an issue in the firewalls, and we're trying to buy systems that will cross-talk to, like you were talking about Polycom and things. So that aside, whenever I was talking to the GPs and they were talking to me, and most of the Queensland GPs had admitting right to the hospital, so they will actually go to the hospital and use the system. But for the people who couldn't go to the hospital, I actually cheat the system a bit, and I go to the clinical school computers and use the Skype. So in that way, I can still provide some follow-up consultations and second opinions for GPs who cannot afford the big systems.
Can I ask, when it comes to using the GP's services in the hospital or in an emergency department or the systems you describe, the government Medicare benefits and the incentives don't seem to quite apply there. So in the last 100 or so cases, or 100 cases that we audited for the ophthalmology ones, only 3%, 3 cases, actually had the provider naturally using the Medicare rebate, because the other people were in emergency departments or optometrists or in Aboriginal health clinics where they are salaried. So it's an interesting problem with the incentives not quite reaching the target audience.
Well, in fact, there's a question here from Natalie Wisher, and I'll just read it out. My name is Natalie Wisher. I'm a credentialed diabetes educator working in the area of telehealth. Currently, I'm not funded to provide an online telehealth service to my clients unless it's with a specialist such as an endocrinologist. Just wondering what progress is being made towards allied health professionals such as diabetes educators being eligible for government funding rebates. Isabel, do you know?
At the moment, unless you're a nurse practitioner, you're not covered for telehealth consults using the Medicare rebate. So
paradoxically, a diabetes educator who's a nurse would get rebated, but
yes,
not
absolutely, but not a diabetes educator who may be a nutritionist or something else. And that's one of the big problems that we have in Australia with the expansion of telehealth services, is that it doesn't cover all the professions. It doesn't cover ophthalmology. It doesn't cover a lot of a lot of the allied health services.
But we bang on about diabetes all the time. Surely it's about time diabetes educators, who are a core part of the team, get on board.
Absolutely, absolutely. So that will take a bit of lobbying, bit more lobbying from the rest of the health team, and we do need them as part of our team.
And also, Isabel, to be fair to the system, in face-to-face life, there's no rebates for diabetes educators and allied health. So if you're comparing face-to-face with telehealth, government might argue this actually...
Get over it and just get on with it.
Yeah. Because we actually started it well before the MBS items. So the first 600 consultations we did for service only.
Yeah, but you were saving $2,000 a transport.
Yeah, so it's only the last year or so, since July, we were getting paid, but before that, it was a service delivery.
Yes.
Let's go. I just want to go, before we go on to poll question 4, which is asking you, if you're not using telehealth, what is the main thing that's stopping you? You don't know where to start? You feel that you don't have the technology, or there's slow internet speed? You're too busy to do the planning? You don't know who to link to at the other end? And patients don't like it? Let's hear what your answers are to that question. So let's go to South Australia, where we're going to hear from a patient and a specialist about their experience of forming an effective doctor-patient relationship using video conferencing.
Hi, my name's Michael, and I have a mental illness, and the type of illness I have is schizoaffective disorder, which effectively means I get depression, anxiety, and mild schizophrenia, or I hear voices. All of that means is that I need to see a psychiatrist regularly. And the reason I need to see it regularly is I can relapse and I can recover and I can relapse. And it happens quite quickly sometimes.
I've been seeing Michael for about 5 years as his psychiatrist. He has previously had admissions to hospital, but in recent years we've been able to avoid him coming to hospital through intervening fairly regularly with telehealth consultations, and I think that's very helpful for Michael and his family. Michael is very comfortable with telepsychiatry, and we have a fairly relaxed approach where he describes some of his recent problems. We review his medication and talk about strategies for his improvement.
I've found that seeing Dr. McKenny on the telemed, I've been able to build a really good relationship with them at a professional level from their side of things, and from a patient to doctor relationship for me. There's still the confidentiality, there's still the fact that what you say doesn't go outside the room.
That's from South Australia. And we actually got a question here online. Is telehealth a good option for mental health patients? From Shelley Reynolds from an Aboriginal Medical Service. With issues you need one-on-one support with a psychologist or psychiatrist. Ewan, what's been your experience?
We've had a lot of experience in the past with psychiatrists talking with our patients in our rooms, and it's worked extremely well. There's been no difference with the rapport and the relationship, and also the level of understanding of the patients with regards to their treatment programs and follow-up. It's been very well received and enthusiastically received by people.
Do you think there's a consumer issue over confidentiality, Carol?
Look, I think the important thing is that consumers who are using these services have an opportunity to understand what the service provides and what the limitations of the service might be, whether that be concerns about the technology and some of the privacy limitations, for instance, and that they feel comfortable. They feel as though they're committing to doing something that is for their best healthcare interests, and that they're comfortable with the parameters around that. And I think if there's good informed consent, then I think it has real potential to provide enormous benefits to consumers who are really
Telemental health
committed.
services have been the longest running telehealth services in Australia, going from the 1990s, and have probably been the highest researched services. They are very, very well accepted by consumers, and they've really led the way in actually teaching the rest of us how to build a patient rapport, and then how to consent patients so that you're not actually putting that consent up front.
I might put this to Angus. I mean, we don't consent patients when you refer. So if I were to refer somebody with a cataract to you, Angus, I don't do an informed consent. Why should there be informed consent for telehealth?
I think, as has been mentioned, when the telehealth situation is something that's a bit new, and the awareness of what is actually happening is important for the patient to understand, and they need to be aware of who's listening into the conversation, anyone else in the room, standing perhaps behind the camera, or a medical student, etc. And then I always ask the patients whether they're happy to proceed, because for my area, it isn't actually quite the same. Unlike perhaps an oncology consult or a psychiatry consult, I don't actually have a chance to look at the person's eye myself. I do have images which are good, but I do actually verbally talk to the patient about the advantages of telehealth, but the fact that I'm not able to use the equipment myself on their eye.
So have you done?
Are they happy to proceed?
So have you got any data on quality of care and safety of a telehealth consultation in ophthalmology?
No, we don't, and it's an area that is actually being researched right now.
But you would have. What about anecdotally? You would have seen, have you missed, a retinal detachment, for example, or something like that?
Well, fortunately, anecdotally, these sort of things haven't happened, because I think we've been on the very much cautious end. And a quarter of the patients I've seen on the internet or on telehealth, I've followed up in real life. We've relied on some good technology, but occasionally we'll say, that image is not clear, I can't see what's happening there, and I'm worried about this, you need to come to Perth. in my setting. So that's actually still happened in 3 cases. People were still flown down for an urgent checkup.
But for routine care with eyes, it's, you know, the images are extremely good, just as they are with the ears for telepathology, and so it really allows the specialist at the other end to get a great view and can ask the local specialist.
It's a huge difference between the description. If someone's trying to describe on the phone what they see on the eye, and they're saying the black bit next to the white bit has a spot on it, compared to an image where I can instantly see the picture, it's a huge advance. And the area of retinal screening for diabetes has a long history in telehealth, far before this rebate. It's a bit like psychiatry, and that has been studied extensively with large systematic reviews showing that a photograph taken without dilating the pupil by a health worker as opposed to a specialist eye camera person is good enough and acceptable for screening for diabetes. And that area is continuing, even though that is a different part of telehealth to what we're discussing today. It's not the chatting bit on video consultation, it's more storing an image and sending it later.
Ewan, just on the quality of care, I mean, if I had cancer, I'd want to be examined by a medical oncologist to lay their hands on me. And if they're not going to lay their hands on me, I'd be wondering whether or not I'm getting the same quality of care.
There'll always be people that obviously want hands on them, and there's
well,
two issues.
The question is whether or not we're missing anything by
Well,
not.
this is right. I mean, this is where, with telehealth, you really have to think about your scope of practice and what's appropriate. Look, telehealth is a team-based thing. It's teamwork between the specialist and the GP or the nurse. And you have to be logical and consistent about this. There are some times when it might be appropriate for that person to go away. And you always have to have a fallback position with telehealth. I would be concerned if we were going to say that telehealth is always going to replace a face-to-face consultation.
No.
I think it's reasonable that it is the first choice, and when you're thinking about whether to send the person away or to have a telehealth, so can I do this by telehealth? But you have to have a fallback. If there's a poor quality reception, if the specialist is not happy that they're completely comfortable with what they're seeing, then it is essential that you have a way of getting that patient to see the specialist.
And I would also add that I think the patient actually has a very key role to play in that decision, and I think as a partnership with the practitioner that they should be involved in that decision about what they're comfortable with too, and whether they want the hands-on approach or whether there's another approach that they're comfortable with.
But maybe medical oncologists don't bother examining people, you just do tests all the time.
Yeah, it's actually true, because when it comes to cancer management, especially the follow-up ones, after you finish your treatment for, say, breast cancer, the investigations don't make any difference. That's the research shows that. So we actually don't even in face-to-face, we don't do bone scans, CAT scans. So it's simply examining the lymph nodes in the supraclavicular area, axillary, the breast examination, and maybe chest and abdomen. Any registered medical practitioner should be able to do that, and we will trust that. And that happens even in a tertiary centre. Half the patients are not seen by the specialists.
I mean, that's the power of telehealth in a way, that you can screen the people that are going to need to go away. You get some information about what tests would be essential for that person to have done. Look, I had a person needed to see a haematologist. I mean, the haematologist just had to look at some full blood count pictures and say, well, yes, this is what we're going to do. Now, if we'd needed a bone marrow, we could have organised that and whatever. But traditionally, I would have had to send that person 1,000 kilometres to see the haematologist, wait a couple of months to get an appointment, and then come back again. So 2 months' worth of worrying to look at a full blood count. So it's a very powerful medium.
And that's where SARB's example of first initial consultations is really good, because you've got the referral from the GP, then you do the consultation. You're a specialist. If there's something that extra that you want that hasn't been done in the blood test, the patient hasn't wasted, you know, a 300, 400, 500, you know, kilometre round trip, or, you know, a couple of thousand. They can get done before they actually have to see you.
just want to go to the results of question 4, which is, if you're not using telehealth, what's the main thing that's stopping you? Over half of you said you don't know where to start. Very few of you think there's a technology problem. Very few of you think you're too busy to do the planning. Quite a few of you don't know who to link to, and patients don't like it. We'll come back to you don't know where to start, but who to link to, Isabel, does seem to be an issue. You know, how do you know if there's a SABE on the other end?
That is a very big issue, and I think for specialist services around the country, whether they be oncology services, wound care, nurse consultant, nurse practitioner, or any other type of service, we haven't really established very good registers of those yet for people in general practice, and there are some being established through the Royal College of General Practitioners where you can go and find out who's available. Within most of the departments of health, there are specialist services who will let you know that they're running telehealth services such as SABE's service. But for a lot of people, they really have no idea if they're a GP working in GP land.
I'd challenge that. I mean, I think you go local. I think you pick up the phone and you talk to your local specialist and say, let's do a telehealth.
So you push the issue?
You push the issue. You say, look, I've got patient X and they need to see you fairly quickly. Would you mind doing a telehealth consultation? And giving them some options, Skype or whatever. Something really simple for the specialist to understand. But the other thing to say is that we've got the ACRM, a College of Rural and Remote provider database, which is actually very well populated now. And I actually have very little difficulty getting a specialist.
Because it doesn't have to be somebody, in the catchment area of Emerald. You could go to somebody in Perth if you wanted to.
Yeah, Perth or Melbourne or...
But one of the things
on that point though,
Yes.
can I interrupt as well? I think
Absolutely.
there's a really distinct advantage to having a provider that knows the area and has the potential at least to be able to follow up in person or arrange for follow-up back in the city. So obviously not always possible. The kind of service that SABE's got going there is fantastic because there's this continuity, whereas just calling an oncologist in Perth to talk about that catchment area is potentially a lot more difficult. And
it
I think
sets
as
up
much as
really
possible,
big problems within the health system because specialists should be providing services to a particular group of people, and if you're trying to actually link a whole range of services which might include allied health and specialist medical services, it's got to fit in the system.
Let's just flick through a few questions before we come to where to start, because we haven't got a lot of time left in the programme. We really do need to get down to some of the technical stuff about what to do and how to do it. A maternal and child health nurse, Lael Ridgway, asks from Melbourne, or from Victoria, asks, I'm interested in using telehealth to support well child checks in remote areas. Can you address this area in your discussion, please, Isabel? Are you?
Yes, absolutely. You can do well child checks, but are you going to be reimbursed, Medicare reimbursal? If you're not a nurse practitioner or you're not working in a general practice as a practice nurse, no, you won't. But you can definitely do well child checks, and you can be having the child with you and linking, no problem.
Also, Janelle from the Australian Medicare Local Alliance asks how useful telehealth is if people move between towns, or in Aboriginal communities people go to see relatives and so on.
I'm glad you asked that question, because actually at least 4 or 5 Aboriginal patients I had, they moved from town to town. So very first time I saw a patient in Mornington Island with his family, and then I said, I'll see you. I just needed to, it was lung cancer, so just needed a chest x-ray. I said, I need to see you in 6 weeks' time with a chest x-ray, which can be done in a small hospital. He said, I'm going to be in Dumaji in 6 weeks. I said, okay, I'll see you in Dumaji. He said, oh, you're stalking me and following me. And then the next trip actually was in Mount Isa. So it was fantastic for that particular patient.
Otherwise, people don't have to restrict their lifestyle or their cultural needs.
I think the other issue too is the personally controlled electronic health record, and I think it's something that we have to be very conscious that that's coming, and that's really going to empower this sort of keeping that continuity. going. And for people we're dealing with telehealth, again, it's shared record between specialist and primary care provider that'll be so important.
There's a question here which I don't really follow. It's Janelle, also from Medicare Local Alliance, asking if one of the reasons for low uptake is that GPs don't have their own independent telehealth item numbers. Is that true?
No, GPs do have their own telehealth item numbers. They're time-based, based on the amount of time you spend with the consultation with the specialist. I think there's a general reluctance because it's new and people don't necessarily see the value in it. It's all a little bit too hard, and I think it's about getting over that hump and realising it's tremendous service for your patients, but also it's a great educational opportunity for yourself and for your registrars. That I teach GP registrars. They sit in with what better way to learn about oncology than to sit in on a patient consultation, your patient speaking with an oncologist about the condition, and the registrar learning about that process at the same time.
Do you have your practice manager set up that link for you, or do you just do that straight from your office?
No, look, you have to have some structure around it.
Yes.
There has to be someone within the practice whose responsibility it is to facilitate that. And it quite often can't be the doctor, because the doctor's either too busy or gets called away or whatever. So somebody typically...
Or as a klutz.
Or a klutz. But yeah, there'll be somebody in the practice whose responsibility is to facilitate that.
Would you call them your clinical champion?
I call them my wife.
So let's get down to brass tacks now. We've convinced the 70% of people watching that who haven't got it, they're going to do it. What do they do tomorrow morning?
Well, tomorrow morning I'd go down to Dick Smith and buy a camera, talk to your local Telstra or Optus or whoever dealer you've got about getting an internet connection if you haven't got one already. Ringing up
You need broadband.
You need broadband, yes. And getting on to...
You don't need broadband.
No, you don't. We haven't got broadband in Pinaroo, and we probably won't have it for the next 7 years, and we still manage quite well.
I'm sorry. Yep.
So you've got the intensivist guiding you from a dial-up connection. Do they sound like Stephen Hawking or what?
You'll have to ask them, but they think they go quite successfully. Their feedback to us afterwards is that they go quite well, and they feel as though they've made a difference as well.
That's ISDN.
Yeah,
that's ISDN.
That's
we've got an ISDN one in A&E, and we've got a digital one sitting out in one.
So that is broadband. That's in fact better than broadband. So it's not really a dial-up connection.
No.
Yeah.
No, dial-up's
too slow.
Too slow. Yeah. No, you do need some form of broadband. But look, and then you just need to pick up the phone, talk to your.
You're talking like an enthusiast. You're talking like an enthusiast. This is like, somebody telling you about your first computer, and if you just do this, this, and this, and you think, no, I'm not going to do it. This is the enthusiast talking who likes tinkering under the bonnet. Tell me exactly what you do. I'm a Luddite. I'm frightened of this technology. I don't know where to start. Give me the practical stuff.
The practical stuff.
I've never been into a Dick Smith store to buy anything apart from a DVD.
If you want advice and support, there's the College of GPs, the College of Remote Medicine provides support, but most of the Medicare locals have telehealth officers that are available for consultations and advice on how to get this all up and running. So there's plenty of support out there for you to get up and running.
90% of GP practices are computerised and are having IT support in the practice. So they're used to having some IT support. So get your local IT guy who's probably, 22 years old and say, I need you to set this up for me. I need to be able to talk to these guys on the other end and make sure that I look good. And they can do that for you.
So you buy a camera. You've got your computer. How do you make the connection?
It's all about software and both the specialist and the GPN talking to each other. And a lot of that's just negotiating with the specialist what software they're using. We do a lot of talking with the Queensland Health facilities, and we use Polycom, which is just a...
But that's hospital to hospital.
No, that's GP to hospital.
So So that's via a web browser, or you go into a special web-based program?
It's an expensive Skype. You've got to pay for this.
Yes, you have to pay for it.
It's like WebEx and movie kind of software.
Right. So
But
it's
you can use
essentially
FaceTime on your iPad. It's not, none of these are complicated things to use.
are some more
Skype.
secure than
Or
others?
Skype, yeah.
How often do you use Skype, Angus?
Well, I've tended to use Skype for 70% of the last 100 cases. The 30% that weren't on Skype were using, in a hospital setting, something called Scopia, which is another video conferencing software. But for the optometrists and the GPs who are in a small community or in the Aboriginal health clinics, the Skype has worked very well because people are familiar with it, the patients understand it, and we talk about the fact that we're using an internet connection and say that this is has had some security issues, you know, and we don't really know what those are, but we just mention that at the start and then say, are you still happy to talk about your eye? And I can understand other areas of medicine are maybe more sensitive for people, but people with their eyes are quite happy because you can see them anyway.
And the other simple thing is really find out who else is using telemedicine around your area. And even in Townsville Hospital, when I was in the last 12 months or so, a lot of people knew that we were using, so they actually sit in with us and then say, oh, I said, that's what I've been telling you last.
Right. So it's not as scary once you do it. So really do it is the thing and learn from doing it.
Yeah.
And do you have to register for telehealth with MBS or you just start
No, just start doing it.
and sending the thing? So I want to get another question from you, which is really just checking back on a question I asked earlier. If you aren't currently using telehealth and you've been watching this program, has it increased your desire to use it? Yes or no? There's the killer question. Ewan, what resources are available? You've mentioned some of them.
Well, I've mentioned the College of Rural Remote Medicine's e-health site and the RACGP telehealth site, with a lot of guidelines, fact sheets, but also provider databases and directory support. Also, the Medicare local network has got telehealth officers who are specifically tasked with assisting GPs and specialists in getting up and getting running.
And a lot of the specialist colleges also now beginning to join with ACROM to come up with this kind of advice for people who want to do telehealth.
And the Nursing Alliance is working as well to make sure that they're working closely with ACROM and the colleges.
Isabel, we've got a question here from Terry Ivanhoe, a nurse practitioner in Tasmania, it looks as though. No, Western Australia. How does it work for nurse practitioners to be able to claim Medicare?
Hi, Tess. Yes, it works. We're just establishing that at the moment. It depends where you work. You can certainly put in your claim if you're working in family practice, but if you're working in a hospital, of course, it doesn't work. So if you're out in you know, a family
if you're a community-based
if you're
nurse practitioner.
community-based,
What if you're working in a rural hospital, which is breaking down the barriers, and nurses go out into the community as well? Nurse practitioners go out into the community as well, which increasingly in rural areas is happening. They're not just working in the hospital environment.
Depends if they're working in the emergency department and they're working as an outreach from the emergency department, such as hospital in the home.
So then they'll be salaried, so it doesn't really
if
make a
they're
difference.
linking with the general practitioner. So it very much depends on where you're working and how that arrangement actually is paid for.
Because that could be seen as double dipping if you're getting paid by the government and then you get a
Yes.
Medicare
Or
rebate.
cost shifting, as some would say. Just very briefly, what other things are you using it for now that you've got it? What about education, team building, things like that?
We use it for meetings. We have our monthly senior nursing meeting for our region now. We do that via video conferencing. We use it for education. All of my staff who are doing online upskilling to be an enrolled nurse or even a registered nurse will use the video conferencing for some of their lectures. Previously, the last 2.5 years while I've been studying to be a nurse practitioner, I did Skype every night with my 2 study buddies from the University of Queensland, and I wouldn't have survived without doing that. It's just, you could use it for just about anything.
Yeah, I mean, telenursing and, transferring expert nursing like chemo nursing. We're actually piloting in a town called Ingham. So to be able to do simple chemotherapy in small towns, you use the technology, you have the chemo nurses in tertiary areas or larger centers, and tell or guide the non-chemo nurse how to finish the chemotherapy.
Yeah, and we're using it for renal nursing, we're using it for wound care nursing and a whole range of nursing specialties.
Karen Gifford, an OT from Western Australia, asks, is there currently a database, we've kind of answered that already, a database of participating medical providers, short of phoning each specialist? How do we know who can offer telehealth? Do you want to just remind us of the answer?
Yes, just the Australian College of Rural Remote Medicine has a provider database on their eHealth website, which you can find online. The issue, I guess, for me is, and the opportunity with education training, but also support for allied health professionals is something that I'd really like to see, and how we advocate and move forward in doing all of these wonderful things is really important.
I think just where we've got to so far since telehealth started really in the late 1990s has been extraordinary. We've been asking for Medicare rebates, and we've been trying to get over the barriers for 10 or so years, and I think we're making extraordinary inroads into those problems.
That's fantastic. Now here's the answer. Let's get the answers to that question. If you aren't already using telehealth as watching this programme made a difference, 100% of you say yes. Well done, right answer. And we'll have to redo the programme shortly just to see what in fact has happened to your uptake and usage. What are your messages for people to take home? Angus?
I would say that it's something that you need to try. If you're in a rural area, it really can help your practice. And my father and my brother have used it, and my brother loves computers and my father hates them, and they've both got over the hurdle. So I'm sure anyone can have a go.
Di?
Just do it.
Sabi?
And I have a message for doctors and patients. So doctors, the main aim of these telehealth models are to help the patients so that they don't travel and waste their time on unnecessary travel. So if you keep that in mind, you want to help your patient, talk to someone and start that tomorrow. For the patients, when you see someone on screen, don't look at them like screen. You consider that the other person is a specialist or a doctor or health professional who is interested in your care and they're trying to help you. So make the connections.
And just briefly, do you have to change your style of communication as a clinician? Just very briefly.
Not really. The communication skills don't have to change if you have good communication skills. But certainly using the camera,
your communication skills are in a goldfish bowl if you're on...
So in an ideal situation,
yes.
The only thing I had to change was the using the camera, because a lot of the patients complained that I wasn't looking at the eyes, and
you were looking at the screen instead of the camera.
So now I look at the camera quite often. And the other thing...
Television 101 here.
Yes. And then the other one I always ask is about, who's out there, who is on my end, are the doors closed, just to make sure that they're all done, but nothing really different.
Carol?
Well, there are many people out there that could really benefit from using telehealth, and in terms of the cost savings, in terms of travel time, convenience for consumers, there are potentially enormous benefits. So a lot of those people are currently missing out. So we need to get the technology out there. And I think we also need to be informing consumers about the benefits of this technology, making sure they're aware and helping them to make a decision about whether or not this kind of technology could really help them. I think, certainly the indications are that many consumers would see that as a real benefit in helping them manage their own healthcare. And I think collecting good information about what's currently happening with telehealth services and where we could be going to expand them to provide cost-effective quality services, there's huge opportunity here. We should be doing more of it.
Isabel?
If you have picture-in-picture, make sure that you put that on so that you're looking your best in the shot, so that the patient can also be looking their best if they're on your side.
So Ewan should be wearing a bit of lippy, should he? Or?
Well, he could be wearing a bit, but he needs to be in the middle of the shot. He needs to be well, just, you know, nice shoulders and head. Really take a bit of time getting yourself prepared. Make sure you have all your data that you need, patient data. If you're a photographer, learn to take really good photos so that that can accompany what you're doing, and just get going. It's you know, it can only be of benefit.
I think you did pretty good, Ewan. You're all right.
Thank you.
What's your message?
My message is for GPs is that there's plenty of help to get online and to get going with this. And yeah, just do it. It's a tremendous benefit for your practice, and it's a tremendous benefit for your patients.
Have you seen benefit in recruitment at all?
I have. I certainly have seen recruitment of patients come into the practice because we're doing telehealth.
Well, that's the bottom line, so that's good. The Rural Health Education Foundation is collating a DVD which will have on it many of these resources, as well as a copy of this panel programme. It'll also have the documentary, Stories of the New Bush Telegraph, and the extended case studies, and this is available on order from the RHEF website. And if you're interested in obtaining more information about the issues raised in this programme, or you'd like to watch the programme again, you can also visit the Rural Health Education Foundation's website at rhef.com.au and click on the New Bush Telegraph programme webpage. Now, if you're a health professional, don't forget to complete your CPD assessment form, which can be completed online. You'll receive a certificate of attendance and, if eligible, CPD points. Our thanks to the Australian Government's Department of Health and Ageing for making the programme possible, but above all, thanks to you for taking the time to watch and to contribute to our discussion today. We would appreciate your feedback on the programme. Your comments are very important to us and are used to improve our service to you. Let us know that you watched the programme by sending us an email or a text, and feel free to share any comments about us as well. We'd love to hear your views, good, bad or ugly. I'm Norman Swan. Goodbye, and join us again on the Rural Health Channel. As I said before, the Rural Health Education Foundation is producing a DVD with this panel discussion programme. The documentary, Stories from the New Bush Telegraph, extended footage of the case studies, and a number of resources and tools developed by a wide range of organisations that support practices to set up and use telehealth. You can order your free copy now by going to the RHEF website, rhef.com.au. The Rural Health Channel broadcasts 24 hours a week. To see what other programmes are showing on the Rural Health Channel tomorrow and for the rest of the week, jump onto the Foundation's website and click onto the RHC TV guide on the left-hand side.